Hi, everyone. I'm Ashley Bassett,
And I'm Catherine Logan.
and welcome to Overtime with the Sports Docs. On each of these mini episodes, Catherine and I chat about a new article or new surgical technique in the field of sports medicine. We'll give you our quick take on the most recent data and how this data will impact our practice. Today, we're talking about Cyclops Syndrome after ACL Reconstruction surgery. We review an article published just this month, so hot off the press, in AJSM, titled Risk Profile for Cyclops Syndrome Necessitating Reoperation After ACL Reconstruction. But first, let's back up a little bit. Let's discuss the basics, starting with what Cyclops Syndrome really is. For many of us, being active isn't just about sport. It's about living fully. But when knee pain or ankle instability gets in the way, it can feel like your body is holding you back.
That's where push braces make a difference. The PushMed ankle brace AcquiFlex and the Push Sports knee brace provide the stability you need without locking you down. Sleek, comfortable, and crafted in Europe, they're built to move with you, whether that means training hard, going for a run, or simply staying strong and confident day to day.
With innovative designs that support while allowing natural movement, push braces help athletes and active people alike find relief, prevent pain, and stick with their treatment so they can keep momentum in their lives.
See the difference at bracelab.com. Clinicians can email samples at bracelab.com and mention the Sports Docs for a free sample.
JRF Ortho has some exciting news. Starting early in 2026, JRF Ortho is launching a quarterly traveling fellowship program designed to provide you with hands-on exposure to osteochondral allografts, meniscus, and ligament repair, all in a dynamic and stimulating hands-on environment.
Each fellowship will be led by distinguished faculty with opportunities to learn in different regions across the U.S. Fellows will also get an exclusive behind-the-scenes look at tissue processing with tours at JRF Ortho's partner facilities in Denver.
Every quarter, 3 outstanding candidates will be selected for this unique experience. The first fellowship takes place in Southern California in early February, featuring Doctors Bugbee, Mandelbaum, Merzian, Dean Wang, and Tim Wang. This will be followed by a second opportunity in April.
In late summer, early fall, JRF Ortho will feature 2 exciting options. One will be dedicated entirely to an all-female cohort, with both faculty and fellows coming together to advance women in orthopedic surgery. The other is open to any established orthopedic surgeon looking to explore their knowledge further in allograft transplantation.
Applications are currently open for each of the different options at jrfortho.org or reach out to marketing at jrfortho.org. Elevate your technique. Expand your network. Lead the future of cartilage restoration by applying today.
So I'd never actually, have you ever called it Cyclops Syndrome? I'd never
No,
even
I just
heard
call
that
it a
term.
cyclops. So I hadn't
Yeah.
actually heard it referred to as a syndrome.
But I guess it is. So Cyclops syndrome is when a fibrous nodule, so-called Cyclops lesion, that's what I would normally say, forms in front of the ACL graft, usually leading to loss of terminal or full end range extension, or when you're reaching the end range of straightening. So clinically, athletes can't fully straighten their knee, and they might even feel like a mechanical block, or sometimes people will say there's a little bit of an audible clunk, and definitely feel like their gait or their running pattern is disrupted when they have this block.
Yeah, and it can have psychological impacts as well. So inability to fully extend at the knee can make athletes fear re-injury, hesitate to push in rehab, or feel like their knee is never going to be back to quote unquote normal again. And in some cases, that scar tissue nodule has to be surgically debrided. That's the reoperation in this study that they looked at.
Okay, so we're going to dive into the study a bit more. So Dr. Ting Kong and colleagues at UPMC analyzed 1,163 primary ACL reconstructions. They're performed between 2014 and 2021. The average patient was about 25 years old, and they looked at surgical, anatomic, and patient-specific variables. So everything from graft type and diameter to the notch width, posterior tibial slope, tunnel position, remnant preservation, a lot of stuff.
Yeah,
and they
everything.
even looked at contralateral knee hyperextension. So ding, ding, ding for later.
Yeah, so they looked at all this because the authors wanted to define a risk profile. So essentially, who is more likely to need that second surgery for a symptomatic Cyclops lesion? And overall, in this study, 5.5% of patients needed a reoperation for Cyclops syndrome. So not rare, but also not a staggering number. And interestingly, the authors found no significant association between graft type, graft diameter, surgical timing, meniscus repair, amount of remnant ACL tissue preserved, or tunnel position, and the development of a Cyclops lesion, which I'm not sure I believe,
Yeah.
but more on that later. Catherine.
Yeah, super important because I would say, like, if we hadn't read this article and you say, why do people get Cyclops? We talk a lot about like graft bulk. So,
Mhm.
or, not just the size of the graft, but is the placement of the graft too anterior or too forward? Or was there too much remnant tissue for Cyclops formation? So, those are the things I would have guessed prior to this study.
Yeah, exactly. Me too. I worry about all that stuff. Especially, we kind of talked off camera on this about like the quad. It's a much bulkier graft than BTB. So transitioning from quad to or BTB to quad, I worried, am I taking too big of a graft, too robust of a graft? But really, this study suggests otherwise. Instead, this study found two anatomic factors were found to be significantly associated with development of a Cyclops lesion, and that is posterior tibial slope greater than 12 degrees and contralateral knee hyperextension. And after regression modeling, contralateral knee hyperextension stood out as the independent predictor with an odds ratio of 2.4 for requiring reoperation.
Yeah. So, I think that's super interesting. And, you know,
Mhm.
what does that mean for us? So, what does that mean for our practice? So, first, I think we need to recognize hyperextension as a patient specific risk factor, which we already look at. I think contralateral, like the reason why they were able to get that data is because we're looking at it anyway as far as like a risk factor for injury. The formation of a Cyclops lesion is not necessarily due to like surgical technique, which at least, that's what we've always thought before. It has something to do with the surgery itself.
Mhm.
Um, if an athlete hyperextends easily on that contralateral knee, they're inherently at higher risk for developing a cyclops, based on this finding.
Exactly. And from the rehab and mindset side, that's also huge. We can flag these athletes early and they may need extra vigilance on extension recovery, early motion, and consistent monitoring for subtle extension loss. And that feeds in psychologically, as we talked about at the beginning. Like when athletes are struggling to get back their motion, like it just negatively feeds back and they feel even worse about themselves and like the hardest part of their recovery. If we can help them get out of that phase, that's really beneficial for them.
Yeah, I think it's, we've talked about this on the podcast before as far as like how important early extension is. It's just one more thing that reinforces that regaining that full extension is super critical. And, when extension is limited, even by a few degrees, like that scar tissue can organize anteriorly or like in front of the graft and, set up that Cyclops pattern. So just one more reason to harp on that.
Exactly. For our athletes listening, great reminder. Extension is your first milestone. It's not glamorous. It's not, doing agility between cones, but it's really essential. So don't rush to strengthening or plyometrics or any other part of your recovery until your motion is restored, particularly extension.
Yeah. And I think from the surgical standpoint, the paper is saying remnant preservation, of that tissue graft size, and even your tunnel placement isn't necessarily like the bad guy. They're not necessarily the villains here. As long as there's no graft impingement. So we should still be looking at the end of the case, cycling the knee, is there any graft impingement? We should also maybe like counsel our patients with like hyperextension or hypermobility of their knees differently. And that maybe like we're tighter on our extension goals early. We can have like earlier follow up, and just be a little bit more vigilant there.
Yeah, absolutely. And further on the rehab side, I'd stress active terminal extension work, patellar mobilization, posterior chain flexibility. I know we both already do this, but I think emphasizing that we should also watch for anterior knee tightness and discomfort that could indicate that early Cyclops development.
Yeah, I think it's just one more reason we talk about this all the time that like collaborating like surgeon to physical therapist or athletic trainer is just so important. And if you see that early stalling of extension, it's not just like, oh, you have a little stiffness, but like it could actually be that lesion, that fibrous nodule is forming and that we want to help them avoid that second surgery. So to just like get on it right away.
Absolutely. So to sum it up before we get into our own little discussion on this, so Cyclops lesions are mechanical, not psychological, but the mental impact of limited motion is real. Hyperextension is an identifiable, measurable risk factor for development of a Cyclops lesion, and technical variables matter less than patient morphology and early motion recovery. But let's not throw out our surgical technical pearl babies with the bathwater. Keep putting your tunnels in the right spot, keep doing the right size graft, keep checking your notch for impingement. Doesn't mean we throw all that out, but there are factors that are outside of our control that we need to acknowledge.
Yeah. And, I think that's a fair thing that you brought up, like about the surgical technique. UPMC is obviously a great institution. I'm sure like they're not someone that's going to be behind in surgical technique. Whereas, from 2014, they're not going to be the site that's going to be having all these anterior or vertical tunnels. So, I wonder if this was like a broader community-based study that maybe some of the older techniques were hanging on, that we'd see a little bit more of an impact of tunnel placement. Maybe there just like wasn't enough numbers of like poor placement, but I don't know.
That's a really good point.
What about you?
Yeah,
Are you surprised?
I'm very surprised. So one thing I didn't notice, did they look at gender as a risk factor? I don't think that they did. This was all like technical aspects, right?
Yeah.
And like graft and like mechanical, biomechanical, because I feel like a lot of my Cyclops lesions tend to be in females. And I always had attributed that to perhaps a larger graft and maybe like impingement on a more narrow notch. I don't like to do notch plasties, so I try to stay away from those. And I wonder sometimes with maybe a more narrow notch, could that lead to the development? But I don't think that they looked at that.
Yeah. But I think like you're saying, it's still all the same principles. We don't want to have graft impingement anyway. So you just, I think we're just learned like more things to look for. The hyperextension can be a risk factor. So pay attention to that. So I think that's something, but it's not like we're going to say, oh, don't worry about graft impingement anymore. It's not a big deal. It's still a big deal. But I think just, I like that we have a new risk factor though. I like that we can look at that hyperextension on the other side, because I look at it more as like a risk factor for that person hurting the other knee. That's the thing like I'm always thinking about, but it's a good call out to say this actually impacts their post-operative knee like early on. So, pay close attention.
Yeah, definitely. The knee hyperextension being a risk factor, it did make me a little confused. I'll explain why. It makes sense in that like anterior, hyperextension's going to contact the anterior aspect of the graft, cause fraying, Cyclops lesion. That all makes sense. But for me, like the patients that have developed Cyclops lesions are those that lack extension from day one. They come in at 2 weeks and they're like -2. They come in at 4 weeks, they're like -2, -5. But I swear I'm getting it full at PT. And then we keep following it and there's still that like lacking 2 to 5 degrees of full extension. If we think Cyclops lesions form at 8 weeks and they form because of that trauma, but they've never gotten hyperextended, they've never even gotten extended, how is the trauma on the graft causing that related to hyperextension? That was something I didn't fully understand, but maybe it is that, the posterior tibial slope makes sense to me because your tibia, it's shifting posterior with that slope, which is impinging on the graft. That makes sense. But the hyperextension, I couldn't really connect, given that at least my patients, when they have a Cyclops, it's like almost day one, they're starting to have some issues. It more makes sense like there's scar tissue anteriorly that develops rather than it being an impingement type thing.
Yeah, I think so too. And like the patella mobility, just that's the other thing that I pay a lot of attention to early is like, what does their patella mobility look like? Because they're just like scarring in a little bit anteriorly. Like it all leads to that. So always, always more things to worry about.
Exactly. But I was very relieved that quad graft didn't correlate because, as you and I have talked about, we really like quad graft, especially for our female patients. And I think, yes, we need to make sure not to harvest an 11 graft and stuff it into a tiny female notch. But I think the fact that it's not associated with that, I think was very, relieving. That's not a surgical technical thing. That's just a graft choice thing. So I was very pleased to see that out of this paper. So lots to take away. Great find. I'm really glad you found this paper. I think it's really awesome and adds to our discussion on this topic. Yeah.
Awesome.
Well, Thank you, everyone, for listening to our Overtime chat. We hope you enjoyed our conversation. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, or wherever you get your podcasts to stay up to date on all things sports medicine. You should also watch us on YouTube. If you like what you hear, please consider subscribing and leaving us a review. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocpod. We love your feedback.